Thank you very much. I appreciate the invitation to speak this afternoon. I appreciate you sticking through to the end, although I think there's one more speaker after me. And I have no disclosures. The topics I was asked to speak on are abnormal uterine bleeding and menopausal syndromes. And then I have a few slides at the beginning that I hope are compelling and thought-provoking in helping us think about overcoming stigma in women's health and also talking to women about periods. The first one is this idea that women's health histories, including menstruation histories, are frequently stigmatized, leading to incomplete histories followed by under-recognized, underdiagnosed, and undertreated gynecologic and/or hematologic problems. And this is compelling, and I hope that we can all kind of work toward making that different. A PubMed search for menstruation revealed that less than 4,000 articles per decade for the last 3 decades compared to over 15,000 in the last decade when you search for semen. Compelling. And then 12 to 18% of supposedly fit and healthy women actually have iron deficiency. And we accept a lower hemoglobin level as normal for women. And that is beginning to be questioned because those are all based on very old studies that were probably flawed if women really should have a lower healthy threshold for those numbers. Last one is that a meta-analysis of US and European studies estimated that women with abnormal uterine bleeding have poor health-related quality of life below the 25th percentile of the general population, something that we can help with. I have a few thoughts on talking about periods, and the first pearl is just to ask, tell me about your periods, because often that will result in all the information you need. You know, it lasts 5 days, it's heavy for 3 days, it happens every month, blah, blah, blah. Although if you need more information, then I think it's very important to get specific and ask specific questions, because women could be embarrassed about talking about this, and if you normalize and ask the questions and use the terms pads and tampons, then they will often tell you what you need to know. So some of those questions are, how many days are your periods? How often do you get your period? On your heaviest day, how often do you change your pad or tampon? And then do you wear a pad and a tampon at the same time? And of course, if that's a yes, that's an indication of heavy bleeding. Do you pass clots? And then follow up, how big are the clots? Do you miss work or school because of your periods? Do they interfere with your social activity? These are very important questions because they frame what treatment is needed and the severity for the patient. A few more pearls on that. Important to ask, do people in your family have heavy periods? And have you ever been told that you are anemic? Because again, that shouldn't be normal. Have you tried anything to manage your periods? And then I like this question, what would your ideal period be? And that is going to be helpful when you're starting to frame a treatment for your patient, because some women have a strong preference to have a monthly period, that's important to them, and other women would really like to not have a monthly period, and that's something that, of course, generally we can achieve for them, and it's important to know what they prefer. And then I want to include that if you have transgender men, they may have a uterus, and you need to ask about menstruation. And that would just be, are you menstruating or are you having periods? Just normalize it. And then, of course, to be able to interpret the answers to those questions, we need to know what is normal menstrual bleeding, and this is how it's defined. So women with a normal volume of menstrual bleeding tend to change pads or tampons at 3 or more hours intervals, not less. Use fewer than 21 pads or tampons per cycle. Seldom need to change the pad or tampon during the night. Have clots less than 1 inch in diameter, and they really shouldn't be anemic. So those things are helpful to think about. So our first topic is abnormal uterine bleeding, which I'll say in my practice is really, really very common. And the background, of course, the definition of abnormal uterine bleeding is menstrual bleeding of abnormal quantity, duration, or schedule. And importantly, this excludes pregnancy-related bleeding. So if pregnancy's on the differential, get a urine pregnancy test right then and there, because you have an entirely different differential, which is beyond the scope of this talk. Likewise, we're not talking about cervical bleeding when we're talking about abnormal uterine bleeding. And so they really do need an exam to be able to check their cervix and make sure that we're not really looking at vaginal bleeding or cervical bleeding, we're talking about uterine bleeding. And then postmenopausal bleeding also has kind of a different differential. I talked just a little bit about that, but largely we're talking about premenopausal women. And importantly, these old terms are gone, although we continue to hear them quite frequently, including in my practice. So the definitions were updated in 2018, and so we shouldn't be using the terms menorrhagia, metamenorrhagia, oligomenorrhea, or dysfunctional uterine bleeding, because those are confusing terms and they're poorly defined. And so now it's all of those previously are just under the header of abnormal uterine bleeding. And for that, we're talking about premenopausal women. And I'm having a little trouble. Click. Okay. I have a few cases in here. This is the longest one, so bear with me. And just like Doug did, I'll read it once, and then I'll read the questions and just ask you to raise your hand. So this is a 25-year-old woman with years of heavy menstrual bleeding. She uses pads and tampons concurrently and changes them every 2 hours and at night for the first 3 days of her 5-day cycle. Her periods are regular and her menstrual cramps are mild. NSAIDs have not helped. She misses work on her heavy days. She has a female partner, and on past medical history, she's had episodes of epistaxis. Family history, her mother and sisters also have very heavy menses, and her mother has now had a hysterectomy. Her body mass index is 26, and her exam is unremarkable. Her urine pregnancy test is negative. In addition to a transvaginal ultrasound, CBC, and ferritin, what is an appropriate evaluation? A, TSH and prolactin, B, PTT and PT, C, PTT, PT, and von Willebrand's panel, or D, TSH, prolactin, PTT, PT, and a von Willebrand's panel. So who says A? Okay, got some. Who says B? Coags, C, coags, and von Willebrand's panel, yes. And then D, TSH, prolactin, and kind of do it all. And so I think the correct answer here, for those of you who chose C, I would recommend that. And the reason is, since this is heavy menstrual bleeding, then you don't need the TSH or the prolactin, so those are for irregular menses or galactorrhea or amenorrhea. And then this woman's giving a history that's concerning for coagulopathy, and so we need to check coags and the von Willebrand's panel. And then remember, the CBC and the ferritin and the transvaginal ultrasound are looking for other things, and then just looking for anemia, of course. And unfortunately, it doesn't work too well. Do you want to advance the slides? Okay, can you go back one, looks like? Okay, forward. Okay, click one more. There's something missing on that side. Okay, sorry, keep clicking. So these are causes of abnormal uterine bleeding, and the way to remember this is Palm-Cohen, which is kind of a funny thing, but it actually does stick in my head. The structural causes are polyp, adenomyosis, leiomyoma, and then importantly, malignancy and hyperplasia. And then the functional causes are coagulopathy, ovulatory dysfunction, for which we're talking about irregular periods, often polycystic ovarian syndrome, endometrial disorders like endometriosis, and then iatrogenic causes most frequently would be a copper IUD, anticoagulants, or implant like the Nexplanon, and then not yet classified. And then importantly, what you're thinking about is if you have heavy bleeding, then that narrows your differential to fibroids, adenomyosis, bleeding disorder, or iatrogenic. If you have dysmenorrhea, then adenomyosis, so those are particularly painful periods. If you have irregular bleeding, ovulatory dysfunction or malignancy, and then intermenstrual bleeding and endometrial polyp, although that could be cervical bleeding or malignancy. Can you advance? And go ahead and click. It's kind of funny looking there. Thank you. And so your evaluation, of course, remember that you need to start with a urine pregnancy test if there's any chance of pregnancy, and then a history and exam, and then a CBC and a ferritin because, of course, your patient is bleeding. And then your evaluation includes these basics. So transvaginal ultrasound is looking for structural causes. Endometrial biopsy, I'll talk about in a little bit. And then coagulopathy is your coags on the von Willebrand's panel if bleeding elsewhere or a family history. And then a TSH if it's irregular menses or amenorrhea, and the prolactin if irregular, amenorrhea, or galactorrhea. Go ahead and next slide. So fibroids, leiomyoma, and adenomyosis are relatively common. You'll often pick these up on your ultrasound. And I wanted to call this out because this is higher incidence in Black women, and there are multiple stories of Black women having a delay in diagnosis and very heavy menstrual bleeding that has been kind of normalized for them. And this may be asymptomatic or cause heavy menstrual bleeding, pelvic pressure, sometimes pain if the fibroids are involuting or twisting. And then adenomyosis is when the endometrial tissue is growing into the myometrium, and then you might feel that on exam with a globular uterus, and they have painful periods, and they're heavy, but they are regular. Go ahead and advance. And advance. And then coagulopathy is one of the things I want to emphasize in this talk since it's underdiagnosed. So women may experience significant delays in diagnosis, and this is shown in this cohort study from 2021 of over 1,000 patients, of which over 600 were women, and they all had autosomal inherited bleeding disorders, and the researchers investigated sex differences using bleeding scores and patient questionnaires. The age of bleeding was similar for men and women, and yet the time from first bleeding to diagnosis was much longer in women, so a mean of 11.6 years versus for men of 7.7 years. Go ahead and advance. So approximately 20% of women with heavy menstrual bleeding have a bleeding diathesis, and so that could include nonspecific platelet disorders, von Willebrand's disease, or a hemophilia carrier state. And a hemophilia carrier state is actually a misnomer because women who carry the hemophilia gene actually have significantly more bleeding, and it's not a benign condition, although they don't have full hemophilia. So we think about von Willebrand's disease as the most common inherited bleeding disorder, 1 in 1,000 in primary care, so we've probably all seen this. And they have mucocutaneous bleeding, so this is heavy menstrual bleeding, and then they may have gum bleeding, which is a little hard to tell because, of course, you have gum disease, but then epistaxis would be your other clue. Testing should be done if they have a positive family history of von Willebrand's disease or a phenotype, a family history that's suggestive of that. And the pearl there is that women and families often normalize heavy bleeding because everybody in my family has these terrible periods, and they could have undiagnosed von Willebrand's disease. And then the mucocutaneous bleeding, like I mentioned. And so the test you would do is a von Willebrand's panel, and that measures von Willebrand's level activity in factor VIII. And of course, a referral to a hematologist would be the next step after that. Go ahead and advance. This is just... Okay, so next case, a 35-year-old woman with a past medical history of obesity, a BMI of 41, irregular periods with 40 to 60 days between cycles, and a recent history of a very prolonged period lasting a month. No other past medical history or meds. Her exam is unremarkable. Her pregnancy test is negative. Her TSH and CBC are normal. Her ferritin is low. Her pelvic ultrasound is normal. Should she have an endometrial biopsy? Yes, because of the prolonged menses, B, yes, because of her age. C, yes, because of obesity and irregular bleeding. And D, no, the normal ultrasound is adequate evaluation. So who says A? And who says B, age? Who says C? Couple for that, and no, the ultrasound's adequate. Couple for that. Okay. I think the correct answer here is that she should have an endometrial biopsy because she has risk factors for endometrial cancer, which are obesity and chronic anovulation from that irregular bleeding is suggestive of probably polycystic ovarian syndrome. Next slide. So this is the summary of who should be evaluated for hyperplasia and malignancy. So we're otherwise not talking about postmenopausal bleeding, but in those women, if they have bleeding, then the next step is a transvaginal ultrasound. And if they have a thin endometrial stripe, then nope, you're done. The negative predictive value is high enough that you don't need to proceed with a biopsy. However, of course, if a postmenopausal woman has a thickened endometrium on that ultrasound, she needs a biopsy. And the pearl over there in the alert is that endometrial thickness is not helpful in premenopausal women because normal major variation occurs with the menstrual cycle, so it doesn't help, it doesn't rule it out. You could see a polyp, but largely you're looking for fibroids, adenomyosis, polyps, but you're not evaluating the stripe on a premenopausal woman. And then age 45 to menopause is a higher risk for endometrial cancer also. So essentially any abnormal uterine bleeding in that population should proceed to have an endometrial biopsy, which is summarized there. And then under 45, this is the point of that case. So if somebody has persistent bleeding and they have risk factors, then they should have an endometrial biopsy. Next slide. And these are the risk factors for endometrial cancer. And some of these are for postmenopausal women, which of course increasing age, and endometrial cancer increases significantly after age 45, but does occur, I think it's 9% of cases are in women under 45. Unopposed estrogen, which hopefully we're not specifically doing, but occasionally you see that. Tamoxifen increases risk of endometrial cancer. A late menopause would as well. And then chronic anovulation, polycystic ovarian syndrome is a significant risk factor with a relative risk of 3. And then obesity is a significant risk factor, and you can see the higher the body mass index, the higher the risk. Basically, with a body mass index of 40, then you're similar to having chronic anovulation, and that's because of increased estrogen in the adipose tissue is converted to the active form of estrogen. Diabetes also increases risk, and then there's a couple genetic syndromes, Lynch and Cowden syndrome. Next slide. This is a study that shows that abnormal uterine bleeding is actually very common in the menopausal transition, and this is something that's going to come up in primary care frequently because people ask what is normal. This is an analysis of 10 years of menstrual diaries of women aged 42 to 52, and their periods ranged from 1 to 132 days with a mean of 6 days, and 78% of women had at least 3 episodes of menses lasting greater than 10 days. 2/3 had 3 episodes of spotting, 1/3 had 3 episodes of heavy bleeding. So when a woman in the menopausal transition is asking about their changes in their bleeding, then it's important to say that could just be normal menopause, because that's pretty common, but that doesn't preclude proceeding with the regular evaluation given the elevated risk of endometrial cancer after age 45. Next slide. A 40-year-old woman with regular heavy menstrual bleeding for the past 6 months. She has a normal BMI and no meds, no bleeding elsewhere, no family history of bleeding, and her evaluation, including an ultrasound, is normal. If she wants treatment, does not desire fertility, and is open to all options, what is the first-line treatment for her heavy menstrual bleeding? Is it A, an oral contraceptive pill, B, a levonorgestrel IUD, C, naproxen during her menses, or tranexamic acid during menses? Who votes for A? Okay, good. B, levonorgestrel IUD, got some people. Naproxen and tranexamic acid. Okay, nobody there. Next slide. Next slide, thanks. So I think the correct answer here is a levonorgestrel IUD. And so this is for women who have ovulatory or anovulatory bleeding without an underlying structural cause like fibroids or coagulopathy. Then you have multiple treatment options, which are all listed there. But there is a randomized control trial that suggests that the levonorgestrel IUD was more effective at reducing heavy menstrual bleeding and improving quality of life for patients in this situation. And it is specifically FDA approved for heavy menstrual bleeding, not just for contraception, which is something that I'll probably comment to patients because that makes it more appealing to them that this is a totally legit use of the levonorgestrel IUD. However, all of those options could be used, and so that would be shared decision-making. So, of course, if your patient does not desire an IUD, then any of those other options could be used. It's also a very nice assistance to transition to menopause, given that periods change and get heavier, and to go through your 40s with a levonorgestrel IUD might be appealing for many women. Next slide. Tranexamic acid has been approved now for years. It's generic in the US. It's actually over the counter in Sweden. This would be within the wheelhouse of primary care to prescribe. It blocks the conversion of plasminogen to plasmin. It reduces fibrinolysis, and there's study evidence that it significantly reduces heavy menstrual bleeding. And so this might be appealing to somebody who does not want a procedure of an IUD and wants to take something as needed that is effective and is safe. And so it's 1,300 milligrams 3 times a day for just the 5 days during menses. And so it's not a daily pill. It's just something that they take during their period, and it does not cause clots. Next slide. All right, so the next topic is menopause, which I'll comment is incredibly common when we think about conditions that people have in our clinics. If you have a reasonable number of patients, you will encounter a lot of women experiencing menopause. And in a primary care practice, perhaps a little different than OB-GYN, a lot of women just want to know what's normal, and that it's important to be figuring out, are they asking what's normal, or how significantly impacted are they by their menopausal symptoms? And so I try to determine that early to make sure I'm providing the care they desire. Next question. A 50-year-old woman sees you for frequent hot flashes, night sweats, disrupting her sleep and impacting her job. Her last period was a year ago, and she asked for help with these symptoms. She has no significant past medical history. Her father died of a stroke at 72, no breast cancer in her family. Body mass index is 28, blood pressure 120/80. What do you recommend? A, lifestyle measures. B, black cohosh and soy isoflavones. C, venlafaxine. Or D, hormone replacement therapy. Who chooses A, lifestyle? And B, venlafaxine, C. And hormone replacement therapy. We got some folks for that, which I think in this case, this is a woman who's significantly impacted by hot flashes and is young, and low risk of breast cancer and cardiovascular disease, that hormone replacement therapy is likely the best choice. Next slide. So, of course, menopause, it's the cessation of menstrual cycle. It's defined retroactively 12 months after the final menstrual period, which is sometimes a talking point for patients when they're telling me how long it's been, 9 months. Well, once it's a year, then you're officially done. And the median age of menopause is 51.4 years. People do lump, right around there, although technically normal is age 40 to 60. And then perimenopause is quite a long period, 2 to 8 years, marked by ovulatory cycles, and the periods get a little closer together, and then they lengthen and get irregular, and more of those cycles turn anovulatory, which could be heavy. And this really is a clinical diagnosis, particularly for perimenopause. Checking an FSH is not helpful. If it was high, they're still having periods. If it's low, they're still having periods. It really does not help at all. And likewise, once periods are done and you're around the age of menopause and FSH doesn't tell you anything either, you know clinically that they're in menopause. Next slide. So symptoms, probably we already know this. Definitively associated with menopausal hormone changes is hot flashes, of which 80% of women will have some hot flashes, night sweats, and vaginal dryness. And then possibly, but not definitively associated with menopause, mood changes, sleep disturbance, cognitive changes, fatigue, urinary incontinence, headache, back pain, myalgia, and sexual dysfunction. Next slide. So as for the duration of vasomotor symptoms, maybe longer than we previously thought. This is a study of about 1,500 women who have vasomotor symptoms. I do want to call that out. This isn't all women, because not everybody has vasomotor symptoms, but this was a subset of women who were having vasomotor symptoms in a larger study. And the median total duration was over 7 years, with over 4 years occurring after the last menstrual period. Predictors of a more prolonged and worse duration of vasomotor symptoms is women who started having those symptoms during the perimenopausal period, which might be worth knowing and recognizing, kind of making a treatment plan if that's what your patient is experiencing. And there was some ethnic variation, with Black women having the longest total duration and Chinese and Hispanic women having the shortest. Next slide. What lifestyle modifications have consistent evidence of decreasing vasomotor symptoms? A, smoking cessation, B, alcohol reduction, C, weight loss, or D, exercise? Who says A? And B? And C? And D? Okay, I got most for C and D, but actually the right answer is A. Next slide. So smoking is really the only lifestyle measure that has consistent and strong evidence of being associated with worse vasomotor symptoms, and actually quitting or reducing smoking of helping vasomotor symptoms. So if you have a patient who's talking about menopausal symptoms and they're smoking, then I would strongly suggest making that connection to try to help them decrease and stop smoking. However, all those other very lovely recommended things, weight loss, exercise, alcohol cessation, they have mixed or poor evidence of improving menopausal symptoms. And the suggestion is that we should be recommending them for long-term health, but suggesting that they'd be helpful for menopausal symptoms is probably misleading and could make your patient feel, blame or guilt if they're not successful. Next slide. And then supplements are just incredibly commonly used. Of all the conditions I treat in clinic, I think menopause is the one most likely that the patient comes in with a book on the subject. And that book will often have a lot of information on supplements. However, the effectiveness of the multitude of supplements that are used is probably limited. The studies are small, they're short duration, and lack of product standardization is problematic. Black cohash is probably the #1 supplement used or discussed, and a Cochrane review 10 years ago showed no effect on hot flash frequency. Soy isoflavones have low quality evidence. And so the kind of take-home point here is if you have a very symptomatic patient where hormones could be helpful, then probably we should treat her with hormones and not recommend supplements, while understanding that many patients want to try these, and I don't tell them not to, although I wouldn't specifically recommend them. Next slide. And then there are many non-hormonal medication options, and these are studied in quality, double-blind, randomized controlled trials. And those include, the ones I'd most commonly use would be venlafaxine, escitalopram, and citalopram. Interestingly, fluoxetine and sertraline were studied and did not have consistent evidence. And the take-home points is that the doses are smaller than for depression, the benefit occurs sooner than for depression, and there is a very, very large placebo effect in these studies. So the placebo group had significant improvement, but these medications showed improvement beyond the placebo group. Gabapentin and pregabalin could also be used, particularly I would think for patients who are having sleep disturbance, night sweats, and for which are not taking other sedatives that those would be risky with. That seems like a reasonable option. I have never used clonidine. Next slide. A 52-year-old woman presents with hot flashes significantly affecting work and sleep. She had a hysterectomy at age 40 for fibroids. She's interested in hormone therapy. What do you tell her about the risks of estrogen replacement as shown in the Women's Health Initiative? A, decreased or no change in risk of breast cancer. B, decreased or no change in risk of coronary heart disease. C, increased risk of stroke. D, increased risk of blood clot. Or E, all of the above. And A, who says A? B, C, D, and E. This is E, actually. So estrogen does all of these things. Next slide. Yeah, thanks. Another click. So, of course, the Women's Health Initiative was published an eon ago, 2002, 20 years ago. And then subsequently, they published the 13-year follow-up. And this is a study that probably just could never be replicated. 27,000 women enrolled in this study. They were ages 50 to 79. And of course, there were two arms to the Women's Health Initiative. For women who had uteri, they had to take estrogen plus progesterone versus placebo. And the outcome of that was an increased risk of breast cancer, a trend toward an increased risk of heart disease, and increased risk of stroke. And that study was stopped early because of harm. And then in the group of women who had had hysterectomies and therefore just needed to take estrogen, then they found an increased risk of stroke, which is the main take-home point. And really no difference in heart disease, and then a trend toward decreased risk of breast cancer, which was actually significant in the 13-year follow-up, so maybe not quite what we would have expected. And the main outcome of this Women's Health Initiative is this answered the question of if progesterone, if these hormones should be used for chronic diseases. And you can note that the enrollment age went up to age 79. They weren't treating vasomotor symptoms specifically. They were treating chronic diseases. And the outcome of that was no, don't do it. And so that's the take home. Next slide. So now contraindications and cautions. So we could not use hormone replacement therapy if people have undiagnosed vaginal bleeding, because that could be endometrial cancer. If they have a history or current breast or endometrial cancer, if they've ever had a blood clot, if they have had a stroke or heart attack or liver disease, a coagulopathy, or if they are pregnant. And then cautions, gallbladder disease could get worse, hypertriglyceridemia, diabetes because of their elevated risk of cardiovascular disease, hypoparathyroidism because somehow that could then drop your calcium, meningioma, if they have intermediate or high risk of breast cancer, which you're assessing based on their family history and then their personal history, which would include any history of breast biopsies. If they have a high risk of heart disease based on risk factors or family history, migraine with aura, sorry about that typo, hepatic hemangioma, epilepsy, or lupus. Next slide. And then I think this is a very helpful graphic. This is from an Annals of Internal Medicine article in 2021, and it really lays out what the kind of standard is now for hormone therapy. And the first box there is to determine the significance of the vasomotor symptoms on your patient's quality of life. And if it is moderate to severe, and of course if it's not, then you shouldn't take the risk of hormone replacement therapy. If it is moderate or severe, then of course you're going to ask the patient and consider if they have any contraindications based on the previous slide, and if they do, they can't do hormones. If they don't have any contraindications, then you're going to assess their characteristics, their age, their breast cancer, their cardiovascular disease risk, and if they're over age 60, or they're more than 10 years out of menopause, or if they have moderate risk of breast cancer or cardiovascular disease, then the recommendation is no hormones. Likewise, if they have a high baseline risk for breast cancer or cardiovascular disease, no hormones. But if you're preceding up to my blue star box, these are the women where you'd be prescribing it. So they don't have any contraindications. They have moderate to severe vasomotor symptoms. They are age 60 or less, and less than 10 years out from menopause, and low risk of breast cancer and cardiovascular disease, then you should recommend hormone replacement therapy. The box below is if they have moderate risk, then you're deep in a shared decision-making discussion with their input, obviously, significantly influencing the decision. Next slide. So hormone therapy, of course, is the most effective treatment of vasomotor symptoms, and that is something to call out. Sometimes women are more concerned about sexual dysfunction or cognitive changes, and the evidence of hormones helping significantly for those is much different than for really hot flashes and night sweats is what we're talking about. The current standard of care is to use the lowest effective dose and to limit the duration of therapy. And then I think we know that if they have a uterus, then you absolutely must use progesterone to protect the endometrium, because otherwise you're placing risk of endometrial cancer, and that would be terrible. And then when people are on hormones, if you're starting hormones or if you're continuing them, then of course the recommendation is an annual in-depth discussion of their preferences, their symptoms, and their risks. And at that appointment, I always ask them if they remember the risks of the hormones, because I want to hear them say, it increases my risk of stroke, and then I want to make sure they kind of got that. And if they do and they want to stay on it, then again, discussion, sometimes we try to lower the dose, et cetera. Next slide. And then these are some options for hormone replacement therapy. It's not inclusive. There are a lot of different products. And the shift since the Women's Health Initiative is to not use the full dose, is to use that low dose on the side there. So, and also oral conjugated estrogens are much less commonly used versus oral estradiol, that's generic. So the low dose would be 0.5 milligrams daily. And then transdermal estradiol, I'll talk more about that on the next slide, but so that's the patch, and that's 50 or 25 would be the low dose. And then if they have a uterus, like we said, they have to be on progesterone, and the choices are progesterone 100, medroxyprogesterone 2.5, or a lot of people are doing this now, off-label use of a levonorgestrel IUD to protect the uterus while not incurring all of those risks that the Women's Health Initiatives showed progesterone did. And then there are estrogen-progesterone combinations, including multiple patches and pills. And probably somebody would have asked, so I want to say it, that the bioidentical hormones are hormones, and those are custom compounded, and they aren't thought to be any safer than commercially available products, and the doses could be quite variable. Sometimes other providers check saliva levels and then adjust the hormones based on saliva levels, but the saliva levels really vary wildly, and so interpreting them is probably impossible, and then following the levels and interpreting those levels is also impossible. And so generally we'd say if you're doing hormones, let's do the ones that have been studied and we know exactly what's in them. Next slide. So a few pearls. So transdermal estrogen is probably safer. So that avoids the first pass through the liver, and so decreased risk of venous thromboembolism. And then, interestingly, women with low libido, which is also a part of menopause, possibly, may choose transdermal over oral for less effect on sex hormone binding globulin. And then low dose versus standard dose, like I mentioned, we are often doing low dose now. This really hasn't been studied in terms of safety, but the obvious thought is less would be safer. And the impact is, of course, they are less effective, and it takes longer to see the benefit. And however, discussion with your patient, reducing hot flashes by 78% is probably acceptable versus 94, really making them go away with the standard dose. And then, like I mentioned, off-label use of a levonorgestrel IUD. And this is also quite commonly used in women in the perimenopausal transition who are already having significant hot flashes, because for them, it decreases the bleeding of perimenopause, and then they can use an estrogen patch to help with the hot flashes of perimenopause without the bloating, et cetera, of a progesterone pill and the periods that come with that. Next slide. All right, just the last few slides here. So genitourinary syndrome of menopause. So previously we called that atrophic vaginitis, and I still generally do, although I think it was 2018 or 2014, it was renamed by the North American Menopause Society. And the reason for that is that women with vaginal symptoms often have urinary symptoms. So the bladder and the urethra are also estrogen-sensitive tissue. And so if we just talk about atrophic vaginitis, we're missing all of those urinary symptoms and not necessarily addressing them. Next slide. So the symptoms are listed there. We probably know them. But most commonly, it's vaginal dryness, burning, itching, and then particularly pain with intercourse. And then urinary symptoms, dysuria, frequency, urethral discomfort, sometimes hematuria, and then recurrent urinary tract infection. Next slide. So a 56-year-old woman has vaginal itching, dryness, and pain with intercourse despite use of lubricants worsening over 1 year. She has no discharge. She's menopausal since 52. On exam, she has pale vaginal walls, decreased rugae, petechial hemorrhages, pH is 6, sweat mount, occasional leukocytes, no clue cells, no hyphae. What is the appropriate treatment? Oral conjugated estrogen and medroxyprogesterone, oral metronidazole, vaginal estradiol cream, or vaginal estradiol tablets. All right, who says A? Hormone replacement therapy. Who says B? Oral metronidazole. D, vaginal estradiol cream, or D, vaginal estradiol tablets. So I think the right answer is either C or D, although D has less systemic estrogen absorption than the cream. Although in practice, and most recently, I'm encountering that insurance may not pay for the tablets until you try the cream. And so I think either is fine, as long as you recognize and discuss that the cream could have more systemic absorption. And so I might discuss that with patients to make sure they don't use too much, they just use the prescribed amount, and that they use the lower dose necessary for their symptoms. Next slide. And so first-line treatments are, of course, not hormones, they're vaginal moisturizers, and so those are available over the counter. I took some residents to the pharmacy yesterday to do a field trip and encountered a woman trying to find these, telling us that her doctor had recommended them. They are used 2 to 3 times per week. It's like glycerin and oil, basically moisturizer for the vaginal tissue. And of course, lubricants with intercourse, and sometimes that's confusing. The moisturizer is separate from intercourse. The lubricants are with the intercourse. And then regular sexual activity may also improve symptoms, which is worth noting, but maybe not emphasizing. And that's probably related to blood flow. And then second line, of course, many women have already tried all those things, and then they come in saying, not okay, I need to take something for this. And so then we have the vaginal estrogens, and so it's cream, tablet, or ring, and more systemic absorption, like I mentioned with the cream. The ring is very appealing, but lately very expensive. Can't seem to get that. Many women say, I don't care what it costs, I want it, but then I get a message a few days later saying, no, too expensive. And then third line, I've never prescribed ospemifene, and that's actually a SERM, and it increases hot flashes and thromboembolism, and so this would really be only for somebody with significant symptoms who's really not willing to do a vaginal product. Next slide. And then these are just general pictures. So loss of the kind of regular tissue in the vulva, decreased moisture, and then sometimes you'll see fusion of the labia minora. And I wanted to call it a urethral caruncle because occasionally you see this, and often you might think it's a tumor. It's actually the kind of overgrowth of that estrogen-sensitive tissue right at the urethra opening, and that is just a part of atrophic vaginitis or genitourinary syndrome of menopause. And that doesn't require any treatment. If that's bleeding, causing irritation, they could use just estrogen cream on it to help. Next slide. That's it. So I'm happy to take any questions.